Hello, everyone. Thank you for this opportunity. My name is Hussain Jafri, and I'm the CEO of the World Patient Alliance. I'm extremely grateful to Global Colon Cancer Association for providing me this opportunity. So let me first introduce World Patient Alliance. We are the world's largest umbrella patient organization that works across all disease areas. We provide that platform to raise and empower patients' voice for the provision of safe, affordable, and quality healthcare all over the world. We also want patients to play a very active role in all stages of healthcare, right from the beginning to the very end of the health spectrum. So we have a total of more than 700 member patient organizations in 137 countries of the world. The title of my presentation, The Dignity of Being Counted, may sound simple, but it carries deep meanings. For patients, being counted is not about numbers, it's about existence, about being seen, recognized, and respected as human beings whose experience matters. When a patient is not counted, their pain and outcomes disappear from the system. Decisions about them, funding, and policy are made as if that person never lived. And when this happens to millions, invisibility becomes a form of injustice. So, as we begin this Congress, I invite us to see counting not as a technical, but as an act of dignity. When we collect data, record a diagnosis, or include patient story, we are not filling a database, we are informing a life. This connects directly to the powerful theme of the Congress, Count Us In: Data, Dignity, and Disruption in Global Cancer Equity. These three words capture both the challenge and the opportunity before us. Data is identity. It shows who is seen and who is invisible, who receives care and who is left waiting. Incomplete data make whole community disappear from view. Dignity is the human side of every health system. When patients are counted, their humanity is affirmed. And when they are not, it is denied. We must build dignity into every step of how we collect, interpret, and use the data. And disruption reminds us that we cannot fix what is broken with the same tool that created the gap. Disruption means questioning old systems, rethinking who collects data and how it is shared, and who benefits from it. Together, these pillars form a single call to action. To achieve real equity in colorectal cancer care, we must collect better data, protect human dignity, and have the courage to disrupt exclusion. So, what does it really mean to be counted? To be counted is to exist, not just medically, but socially and politically. It is the recognition that your life and your experience matter enough to be recorded, analyzed, and remembered. Where a patient is invisible in data, they are invisible in decisions. And when they are invisible in decisions, they are forgotten in funding, policy, and planning. So let me share what looks like in real life. In many parts of the world, colorectal cancer patients never appear in national cancer statistics because their diagnosis was never confirmed by biopsy, or their case was treated outside formal hospitals. On papers, they don't exist. In reality, they are fighting for their lives without access to treatment, pain, or even acknowledgement. This invisibility has consequences. It means governments underestimate disease burden. It means resources go elsewhere. It means lives are lost simply because they were never counted. So when we talk about data today, we are not talking about spreadsheets or registries. We are talking about people. Data collection at its core is an act of respect. It says, we see you, you matter, your life counts. And that is what we mean by dignity of being counted. So the first pillar of this Congress is data, and this is where everything begins. We often say what gets measured gets done, but I would add what doesn't get measured gets ignored. So in global cancer control, we see this reality every day. Where there is a strong data, we see national screening programs, timely diagnosis, and policy attention. But where data are weak or missing, patients fall through the cracks. The problem is just not the absence of data. It's also the bias in the data we have. Most cancer registries count only cases that are biopsy confirmed or reported by formal health facilities. This leaves out large numbers of patients who never reach diagnostic services. Those in rural areas, those who can't afford tests, or those who die before this diagnosis is confirmed. This means the true burden of colorectal cancer is systematically undercounted. And this has real consequences. If your country's data show only 1,000 cases, you will get funding and resources for 1,000 cases, even if 10,000 people are suffering. If your community is not represented in data, you are not represented in policy. Data are not just a technical matter, they are a matter of justice. Incomplete data lead to incomplete understanding, and incomplete understanding leads to incomplete care. That is why we must look at data not as statistics, but as instrument of equity. Without accurate, inclusive data, there can be no control of cancer. As this Congress statement clearly says, cancer cannot be controlled without being counted. So if we look at the global picture, the inequality in counting is striking. Only about 1 in 3 countries has a full functional cancer registry with accurate population-based data. Even fewer cover rural areas. In many low and middle income countries, registries exist only on papers. This means that in much of the world, we don't really know how many people have colorectal cancer, where they live, or how they are treated. We estimate, we model, we guess, but we do not count, and not in a way that reflects accuracy or human dignity. This creates what I call a visibility divide. Patients in high-income countries are visible, their cases recorded and outcome tracked. Patients in poor regions are not. They remain invisible to the system that shape funding and policy. The painful truth is that invisible patients receive invisible care. And if they are not counted, they are not prioritized. They miss out on screening, early detection, and palliative care. This invisibility fuels a cycle of neglect. Breaking this cycle needs more than technology. It needs a commitment to equity in data. The second pillar is dignity, where data meets humanity. Dignity is not about numbers or system. It's about being recognized as a person whose life has meaning and worth. When a patient's experience is not captured, their dignity is quietly taken away. We often speak about the right to health, but that right begins with recognition. You cannot enjoy a right that does not see you, and being seen starts with being counted. Counting is not only a technical act, it's a moral one. When we collect data, we acknowledge a human story. Each line in a registry says the person matters, their life deserves attention and care. And that is why visibility is dignity. To count a patient is to affirm their life and their struggle, to give meaning beyond statistics. Invisibility, on the other hand, denies that dignity and tells patients their stories are too small to record. But dignity cannot be selective. It must include everyone, those diagnosed, those lost before diagnosis, and those never reached by the system. So as we discuss data today, let's remember, each entry is an act of respect. Each patient counted is a life honored. Each person made visible restores a piece of collective dignity we have often overlooked. When we talk about data, it's easy to think in numbers and graphs, but behind every number is a life, a person who hopes, fears, and loved ones. This is a human face of data. Each patient counted represents a story, a diagnosis shared, a treatment started, a family waiting for hope. And each person missing from the data is a story untold. Data gain meaning only when they reflect the patient's experience. That's why patient-reported outcomes and experiences matter. They show what clinical numbers cannot, how people feel, what challenges they face, and what truly matters in their journey. Without these voices, data becomes flat, and we end up designing systems around averages, not people. When patients are part of data collection, not just as subjects, but as contributors, trust grows, evidence deepens, and policy becomes more grounded in reality. Once data has a human face, they stop being statistics. They become a compass guiding better care and fairer decisions. So as we discuss data today, let's remember every point in a graph represents a patient's story, one that deserves to be counted, respected, and used to improve care for all. The third pillar is disruption, and it may be hardest one. Disruption means change, and change is rarely comfortable. It challenges the system and habits that have long accepted exclusion as normal. We must ask questions. Why are some lives easier to count than others? Why do our registries rely on systems many patients cannot reach? Why are the most vulnerable often invisible in our data? To disrupt means to redesign. We need cancer registries that are inclusive by design, not by accident. That means drawing data from primary clinics, community health workers, and patient groups, not only large hospitals. So every piece of information counts, whether it comes from a lab, a home, or a patient's phone. Disruption also means a mindset shift from counting diseases to counting people. We are not just tracking numbers, we are documenting lives in the system meant to protect them. Technology helps, but true disruption comes when we expose who is missing and insist they can be seen. It's not destruction, it's rebuilding, creating something fairer, more accurate, and more human. And that is the challenge before all of us today. The next step, and perhaps the most important, is recognizing patients as partners, not just participants. Too often, patients are treated as data subjects. Their role ends once their information is entered. But patients are not passive sources, they are producers of knowledge. They understand the daily realities of fragmented care, delayed diagnosis, and the financial strain, details that data often miss. That's why they must help shape how data are collected, which indicators matter, and which results are used. This is the essence of nothing about us without us. And when patients co-design data system, the information becomes richer and more relevant. They push us to measure not only outcomes, but also quality of life, affordability, and emotional well-being. Patient-generated evidence through apps, surveys, and patient networks is filling critical gaps and already shaping policy. If we want data that lead to fair policy and real equity, then patient must be present wherever those decisions are made. When we count patients, we create visibility, but visibility must lead to responsibility. If data don't improve care, strengthen systems, or guide fair funding, they must remain numbers. We must move from counting to caring, from recording illness to improving health. Data must hold us accountable to patients who share their stories and to families who trust the system. Behind every statistic is a real person, someone who has faced fear and deserved timely care. When we see that person behind the data, our priorities shift from system to people. So let's not just collect data to report it. Let's use it to heal, prevent, and protect. Because data without compassion is incomplete, and care without data is blind. Only when we connect the two, patients can be seen, heard, and served with dignity. So as we close, I want to return to the message of this Congress, count us in. These words bring together everything we discuss, data, dignity, and disruption. They are not just a slogan, they are a call to act. We must demand better data because what we don't count, we don't change. Data that exclude people deepen inequality. Every health system must commit to complete and inclusive data. We must defend patient dignity because visibility is respect. Every registry should begin and end with recognition of the people behind the numbers. Being counted is a right, not an option. And we must disrupt exclusion wherever it exists. And we have to challenge systems that make some life visible and others invisible, and build new ones that see everyone. And you join today's session and ask yourself, who is still missing from our data, and what will we do to bring them in? Counting patients is not bureaucracy. It is justice and humanity. Let's ensure no one is left unseen and uncounted again. Thank you very much for your patience listening.
Thank you so much, Hussain, for opening our Congress with that very informative and moving presentation and reminding us that what doesn't get measured doesn't get done, and that dignity only matters when people are being counted, and that justice is always at the forefront. So let's take a moment and see who's being counted and left out of the story where you are. So we're going to take a poll. Think about your own country. Whose experiences are missing from cancer registries where you are? Is it rural communities, urban communities, refugees, immigrants, indigenous communities? And we really need your participation. Wow, that's amazing. The results, rural communities, which is consistent with what we've been hearing across the board. Thank you so much for your participation.